Dear AOSIN members, attendees, and the local host, Dr. Yang, and Dr. Feng from Taipei Veteran General Hospital. I'm an pediatric orthopedic surgeon with special interest in pediatric trauma and spine. Since 2008, we start to develop multi-modal operative neural monitoring for pediatric spine surgery with our colleagues, neuro Dr. Liao, Dr. Yu, rehabilitation Dr. Yang, Dr. Chiu, and assistant Dr. Song, Dr. Xie, Dr. Zhu, Dr. Wu, and Dr. Zhou. Till now, we have experienced more than 400 cases. I'm honored to serve this section with Dr. Yang. Our next speaker, Dr. Yoon-Ghil from Yonsei University, Seoul, Korea. Dr. Park has been a research and clinical fellow in Toronto Rehabilitation Institute in 2003 to 2004. Now, Dr. Park is a professor of Department of Rehabilitation Medicine in King's University. He is an expert in this field. Today, his talk is IONM of degenerative spine surgery. Welcome, Dr. Park.
Good afternoon. My name is Yoon-Ghil Park, working for Gangnam Severance Hospital, Seoul, Korea. I appreciate the opportunity to speak here in the third Congress of AOSIN. Next time, I hope we meet each other face to face. Today, I will talk about intraoperative neurophysiological monitoring of degenerative spine surgery. There's a spine hospital at my work, and I'm working together with a neuro and orthopedic surgeon for EMG and intraop neurophysiological monitoring. So we communicated neurophysiological monitoring results with each other to improve surgical outcomes. Today, I will briefly review common modalities in spine surgery and then talk about aging nervous system and aging effects of anesthesia. I will touch major operation in elderly people and its related complications. So, I hope to share my knowledge to improve monitoring modalities in spine surgery, especially degenerative cervical spine surgery. Now I'm going to talk about monitoring modalities in spine surgery. SSEP, MEP, EMG are common modalities for spine surgery as well as other surgeries. Within EMG, there are two different types. Free running EMG and triggered EMG is getting popular for spinal surgery. I will talk about each of these modalities in detail. I believe no single method can sufficiently cover the complex function of brain, spinal cord, and nerve root. So we need to combine some modalities to prevent neural damages. Now, I will talk about combination of each modalities. Neurophysiological monitoring is widely applied in spinal surgery to prevent post-op neurological worsening. Dr. Martinez reviewed evoked potential monitoring degenerative cervical spine surgery. If you look at this table, you can recognize MEP was more sensitive and specific than SSEP, while combination use of MEP and SEP showed better results compared with their separate use. And the authors suggest that sudden signal loss is associated with a severe irreversible injury, while more gradual degeneration is more likely to represent mild, recoverable damages. So, multimodal intraop monitoring could be a helpful tool in the compression cervical spine surgery in patients affected by degenerative spinal stenosis. In the beginning of intraop monitoring at my work, most surgeons wanted for me to do simple evoked potential studies, just focusing on motor tract. But as you know, sensor tract monitoring is also important to prevent neurological deficits. So we try to compare intraop monitoring changes in MEP, SEP, and both together with neurological outcomes. Finally, we had a similar result to Dr. Martinez's work. For combined MEP and SEP changes, sensitivity was low, but on the other hand, specificity was 95%. Sensitivity was measured at 100% on either MEP or SEP changes. Now we are going to look into sensitivity and specificity on different types of spine surgery. For surgery of spinal deformities, the sensitivity and specificity of combined MEP and SEP changes were 100% and 92% respectively. In the case of spinal cord tumor operation, its sensitivity was only 50%, but SEP changes were observed preceding permanent motor deficit in some cases. But the sensitivity was improved to 100% in MEP or SEP changes in spinal cord tumor surgery. So we concluded combined modalities should be recommended, and alarm criteria should depend on different surgery. Now I'm going to talk about EMG of intramonitoring modalities. EMG monitoring is highly sensitive for nerve root injury. However, it is also extremely sensitive to temperature changes like cold irrigation or use of cautery. So it has highly rate of false positives, but it can provide constant feedback throughout cases. So we use EMG for complicated spine surgery like concerning C5 nerve root radiculopathy. If you look at these free-running EMG signals at both tibialis anterior, you can see abrupt activities on both sides. Right side is bigger than the left side. At the same time, amplitude of left tibial nerve SCP was decreased to 78%. So we warned the surgeon, and he ordered the steroid infusion. After that, the amplitude of SAP was recovered. After surgery, there were no weakness and other complications, fortunately. Now, I'm going to talk about triggered EMG. We can use triggered EMG to monitor the safety of pedicle screw placement. Rate of pedicle screw misplacement is relatively high, between 5 and 40%, and its related neurological deficit is up to 11%. It has high sensitivity for medial pedicle breach and relatively easy to perform and interpret. However, its optimal alarm criteria is not firmly established, and it does not directly assess for neurological injury, only provides information regarding pedicle integrity. Now, I'd like to talk about aging of neuromuscular system. Age-related changes to the neuromuscular system can affect the internal monitoring. Here are cross-sectional studies of a relationship between age and the median sensory conduction velocity. Decreased 0.13 to 0.16 meter per second per year. In cohort study, Dr. Tong noted a slightly larger decrease in conduction velocity of 0.21 meter per second per year of follow-up. If you look at these graphs, you can see snap amplitude decreased with age. Snap amplitude decreased with age in all 5 nerves. Women had greater snap amplitude than men in upper extremity nerves. In addition, greater BMI was associated with the smaller amplitude in upper extremity nerves, but not in the low limb nerves. So we should consider physiologic factors during neurophysiological monitoring. Now I'll talk about age effect on anesthesia and its related influence on internal monitoring. This Slovakian research group tried to assess the influence of anesthesia on neurophysiological monitoring. They compared several different types of patients and spanned disorders on MAP responses. If you look at this table, you can see in all the groups, the success rate can decrease due to peripheral neuropathy or age-related changes. All the patients with the mean age of around the 50s in group D, I, and ND underwent an anesthetic phase of 38% amplitude decrease. Spinal deformities with more severe curves and patients with neurologic deficit had a large decrease. So we need to take care about ages, severity of deformity, and neurologic deficit in neurophysiological monitoring. Dr. Chen and his colleagues reported the success rates depended on age, lesion location, and preoperative neurological deficit. The success rate for SCP MAP are shown in Table 2. The success rate of low extremity are lower than those of upper extremities. As shown in Table 3, while the success rate for upper extremity was not significantly affected by age, the success rate of lower extremity MEP was low in under 7-year or the over 64-year age group than age group between 7 and 64. If you look at the last section, the success rate was only 39% for low extremities in patients with preoperative motor deficit, but it's up to 78% in neurologically intact adults. So we should consider to increase stimulus intensity or facilitation when applying internal monitoring in patients with old ages or with a neurologic deficit. Now I'm going to talk about degenerative spine disorders. The degenerative spine conditions involve the gradual loss of normal structures and function of the spine over time. It can be caused by herniated disc, spinal stenosis, degenerative scoliosis or kyphosis, and fractures. Ossification of posterior longitudinal ligaments is a major degenerative spine problem, especially in Asian countries. In our hospital, OPLL and its related myelopathy accounts for a large part of spine surgeries. Ossification of posterior longitudinal ligament is typical disease entities seen in Asian countries, although it can be seen in all ethnic groups. Prevalence of Asian countries is higher than that of United States or European countries. Patients may be asymptomatic or have radiculopathy or myelopathy. If present, symptoms usually manifest in the middle ages. Internal monitoring has become a routine part of scoliosis surgery and significantly reduced the incidence of new post-op neurological deficit. In spinal cord tumors, internal monitoring has demonstrated value as in guiding the extent of tumor resection and allowing the surgeon to maximize the volume of tumor removal while minimizing neurological morbidities. However, there are some controversies and negative recommendation of internal monitoring in surgery for cervical degenerative myelopathy or radiculopathy. This first systemic review, inter-EP worsening is not specific. It may not represent clinical worsening. And the second review article, they revealed the use of internal monitoring were not associated with reduced rate of neurological complications following surgery for cervical degenerative myelopathy like anterior approach and fusion. Here is a positive result of internal monitoring for cervical spine surgery. The authors claim that internal monitoring has associated with a shorter length of stay, fewer readmission, and decreased rate of neurological complications. Now, I'd like to talk about some difficulties in neurophysiological monitoring of spine surgery. We often meet a patient who already have motor weakness or sensory changes associated with deterioration MEP or SEP during surgery. These patients have difficulties to detect the proper change of internal monitoring, or we should consider to adjust intensity like I mentioned before. So application of internal monitoring for patients with pre-op motor weakness is still controversial due to lower success rate and cost effectiveness in spine surgery. Dr. Lee and his colleagues investigated the success rate for patients with pre-op motor weakness in spine surgery. The success rate of both MEP and SCP monitoring were assessed according to the pre-op motor weakness by Medical Research Council (MRC) grade. MEP was recorded successfully 100% of patients with MRC grade 5, but the success rate was decreased 0% in MRC grade 1 or 2. SSEP was obtained from 0% to 85% according to MRC grade. My colleagues and I tried to evaluate that deteriorated pre-SEP would be more likely to have significant changes in intra-op SEP, and it would be correlated with post-op neurological deficit. Prolonged pre-op SEP obtained from prolonged pre-op SEP did not show meaningful correlation with the intra-op SEP changes in overall cases. And there are positive correlation between amount of log loss and maximum percentage of intra-op SEP latency prolongation. Like I mentioned before, the benefit of intermonitoring in deformity surgery have been long established to reduce incidence of major neurological deficit. However, intermonitoring in cervical spine surgery lacked the evidence. Dr. De Cruz revealed the sustained change in both MEP and SEP and was meaningful to predict neurologic deficit in cervical spine surgery. And C5 nerve root palsy rate was about 6%, but there was no correlation with intermonitoring signal loss. Its sensitivity was only 16%. C5 nerve root palsy is a serious complication after cervical decompression surgery, but not easy to monitor during operation. According to Dr. Pan's work, risk factors for C5 palsy included age, male gender, OPLL, and stenosis of C45 intervertebral foramen. Overall, of C5 palsy was 6.3%. The incidence of C5 palsy among the studies varied between 1 and 29%. Based on Dr. Wang's meta-analysis, post-approach male patients and patients with OPLL have a higher incidence of C5 nerve root palsy. Intermonitoring can only detect intraoperative neurophysiological changes while neurological deficit may occur immediately afterwards. So we need to develop a more sensitive method of intermonitoring like free running EMG. Now it's time to wrap up. Here are my take-home messages. No single method can sufficiently cover the complex function of spinal cord and nerve roots. So multimodal intermonitoring method could be helpful. Age is strongly correlated with spine structures and neural functions. So we need to adjust intermonitoring conditions and interpret the result in accord with age and other physiological factors. Myelopathy and C5 nerve root palsy are major complications of surgery for degenerative cervical spine. So we should use proper modalities to prevent these complications. Even if neurophysiological monitoring of degenerative spine surgery needs more evidence to establish its effects. However, I believe intermonitoring is a very helpful tool to prevent neurologic deficit and providing guidance to surgeons. So we need to share our knowledge to develop proper way of neurophysiological monitoring. Thank you.
Thanks, Dr. Pa's excellent presentation and sharing. A question from audience. Does the D-wave has a role for degenerative cervical spine surgery for prevent two major complications in cervical spine surgery?
Thank you for the question. I think D-wave will be helpful for prevent neurologic deficit after cervical spine surgery. But in Korea, unfortunately, there are no epidural catheter for D-wave approved by Korean FDA, and the equipment is very expensive, and then Korean medical insurance does not cover the epidural catheter for D-wave. Actually, I tried the D-wave response with support some equipment supported by other companies. It worked very well, and a neurosurgeon, I think the D-wave should be monitored, especially in the complicated surgery, but currently not available in Korean situation. That's my answer.
Okay. The second question from your specialist. Can you explain why the C5 loop is difficult for monitoring during surgery? That's possible cause and obstacle.
Excuse me, I can't hear very well. Sorry, but can you say again, please?
The question is why the C5 loop cannot be well monitoring during the operation and the possible cause to the failure of monitoring.
I think we need the free running EMG, but free running EMG is not applied for every cervical operation. We tried to the free running EMG in complicated cervical spine surgery, but like I mentioned before, there are many false positive. So we need to check Fourier EMG, SEP, and MEP. So I believe the multimodal intermonitoring system will be the critical point. And that's my answer.
Thank you.